Hello, everyone, and welcome to today's webinar, HIV Diagnostic Testing in the COVID-19 Era, Are Clinical Laboratories Being Overly Sensitive? I am Marie Stone of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Bio-Rad. To learn more, visit bio-rad.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. You may also submit any technical issues here as well if you have trouble seeing or hearing the presentation. I'd like to now welcome our speakers, Dr. Payu Raval, Pathology Resident, NorthShore University Health System, Mr. Alfredo Villarreal, Global Product Manager, Bio-Rad Laboratories, and Dr. Tom Alexander, Clinical Laboratory Director, FlowMetric Diagnostics. Payu, Alfredo, and Tom, you may now begin your presentation.
Hello. I'd like to thank Bio-Rad for asking me to go do this talk. My name is Tom Alexander. I've been an immunologist for many, many years, and I would like to talk a little bit about HIV testing, stuck in a rut. My objectives here, first of all, to talk about the current available tests, then review the current algorithm for HIV testing, asking the question, is it consistent with the current test availability? So kind of tie those two together. And in a nutshell, the answer to that is going to be no, it's not consistent with the current test availability. So we'll discuss some other options and kind of plan out for the future. So most of you are probably familiar with this picture of HIV. It's a double-stranded RNA virus that is enveloped. The main antigens that we're measuring antibody against for HIV testing are the GP41, the GP120, and the P24. Also, the P24 antigen itself is used in HIV testing, as we'll discuss. Many HIV diagnostic tests have been developed over the years, and this is kind of a slide from a number of years ago now, from 2003, but does a good job of pointing out some of the differences in what we can detect and when we can detect it post-infection. So this red bar here shows the initial so-called first-generation HIV serology tests that were available in the mid-1980s that used viral lysates for their antigenic targets, and that picked up infection approximately 6 weeks post-infection, post-exposure. The Western blot, which was the confirmatory test at the time, also picks up antibody about 5 to 6 weeks, so it was a good confirming test for the ELISA at that particular time. The second generation added recombinant antigens to the antigenic mix for the ELISA and brought the testing window, the test negative window, down to about 4 to 5 weeks. Still, the Western blot gave a pretty good use as a confirming test. When we went to the third generation, though, in the 1990s, we now added IgM testing to the milieu. And IgM testing now got us down to about 3 weeks post-infection, but now the Western blot all of a sudden was not really a useful confirming test, even though it continued to be used as one, because individuals infected, say, within 3 to 5 or 3 to 6 weeks post-exposure and being tested would test positive on an ELISA and negative on a Western blot and would be considered to be false positives. So that brought out an idea that these individuals should probably be tested again at approximately 3 to 6 weeks post their initial test. RNA, the viral load or PCR test would be positive within 1 to 2 weeks post-exposure. The P24 antigen, which during these ELISA generations was being used by the blood banks to help close the test negative window, would pick up an infection approximately 2 weeks post-exposure. And symptoms would occur before an individual would test positive on anything except a molecular test. So it certainly was possible to transmit HIV prior to somebody being positive on a test. This is a slide that I got from Dr. Michelle Owen at the CDC. I thank her for that. And here's the Western blot at the time that it's positive. And now instead of calling tests by generations, first, second, third, or fourth generation, the CDC is trying to get down to calling tests based on how early before the Western blot a test would be positive. So the current tests that are available are all over here on the left side of the graph, and they're positive between 3 and 4 weeks earlier than a Western blot would be positive. So as you can see, a Western blot really would not be a very good confirming test for the current generation of screening tests. So the current tests that are out there are so-called combination or fourth generation, or differentiation or fifth generation assays. So the combination assays detect both HIV antibody and the HIV-1 P24 antigen. And this combination reduces the test negative window period by about a week to 2 weeks compared to third generation tests. So now we can pick up an infected individual 2 weeks post-infection. However, this test does not differentiate between HIV antibody and HIV antigen. You get one positive result, and you don't know if that was due to the presence of antibody or antigen. So that brought out the idea of doing separate antigen and antibody tests, and that's the fifth generation or so-called differentiation assays. And here you get separate antibody and antigen results. Examples of this are the Bio-Rad's Bioplex 2200 HIV antigen antibody assay. This test actually differentiates HIV-1 antibody from HIV-2 antibody, plus gives you separate antigen results. The Roche HIV Duo test gives you combined antibody. You get one antibody result with separate antigen results, as does the Abbott Determine HIV-1 antigen antibody combination. You get one antibody result for HIV-1 and 2, which does not differentiate them, and then you get a separate result for the antigen. This is a rapid test. This is a slide from a paper I published a number of years ago now on different HIV testing methods. But the only thing I want you really to look at here is the negative window time here, going from 8 to 10 weeks in the first generation test. Now in the combination and differentiation or fourth and fifth generation, we're now down to 2 weeks post-exposure where we can pick up somebody who is truly infected with HIV. The use of self-testing for COVID has brought up the question, is COVID really a model for HIV testing? Could we have self-testing, home testing, if you will, available for HIV? Well, the answer is we already have it. The oral fluid test, the OraSure test, is available and can be done at home, has a sensitivity of about 93% for home use and 99% for laboratory use. So it's not quite as good for home use as it is in the laboratory. There are many more tests available outside the US, and World Health Organization is recommending this, but at the moment, HIV self-testing really has not caught on too much here in the United States. So this is our current algorithm that we do, and developed in 2014 and updated by Dr. Owen in 2018. And basically, we start off with a combination assay, and if it's negative, it's negative. If it's positive now, again, we don't know if this is due to antibody to HIV-1, antibody to HIV-2, or the presence of the P24 antigen seen in an acute HIV infection. So if we were to look at the results here, we would then go to an HIV-1/2 antibody differentiation assay. This now is the Genius assay. And if the HIV-1 antibody is positive, we have our answer. HIV-2 antibody is positive, one is negative, we have our answer. If both of them are positive, then we sign it out as HIV antibodies detected. Most likely in the United States, this would be due to the presence of an HIV-1 infection with some cross-reactivity against HIV-2. However, depending on where an individual is from, they might be from an area endemic for HIV-2, so this might be a little bit harder to interpret. If the antibody results are negative or indeterminate, you then go to a nucleic acid test, to a third step. This test now has to be an HIV qualitative PCR, not the viral load test. We'll talk about that more in a minute. And if it's positive, this implies that the original positive result was due to the presence of P24 antigen and that the individual actually has an acute HIV-1 infection. If it's negative, it suggests that this first result up here was most likely a false positive, or could be a very early infection with HIV-2. Again, you'd have to determine if the individual came from an endemic area for HIV-2. So there's a little bit more detail as far as how you might sign out reports with these results. And we've really gone over this. I'm not going to go into this in more detail again. Just if you both are positive now, again, you just say it's positive for both antibodies. This is even more detail. Again, don't have the time to go over this in detail, but I gave it to you as a reference. This is from the Association of Public Health Laboratories, and it talks about the actual further actions. So you can use this as a guide as to what to recommend to clinicians based on the reactivities and of all three of the so-called combination assay algorithm tests. So I mentioned differentiating HIV-1 from HIV-2 infection. Why would we do this? Well, first of all, there's different disease progression. HIV-2 tends to progress slower to a full-blown AIDS situation than HIV-1. There are different treatment regimens for each virus. And also for epidemiological analysis to try and track a source or track an infection, you'd want to be able to differentiate HIV-1 from HIV-2. However, it's really not cost effective in the United States at this point. Improved testing for HIV-2 really hasn't identified more HIV-2 in the U.S. Seeing these data from Dr. Rowan, 187 cases of HIV-2 were uncovered and reported to the CDC between 2010 and 2017 in the U.S., compared to over 325,000 HIV-1 cases. So it's far less than 1% of the cases reported are actually HIV-2. And as we all know, low prevalence of any lab analyte that we do would lead to possible false positive tests. So if we're testing low prevalence of HIV-2 populations, we're going to get false positive HIV-2 serologic results, something to keep in mind. So again, is it really cost effective to do HIV-2 testing? So basically, could an HIV viral load test be done as the third step instead of the qualitative test? Most labs following HIV patients have a viral load test on hand. Very few tests actually have the volume necessary to keep an HIV qualitative assay on hand. But the CDC specifically excludes the viral load test from the algorithm. And if you talk to them, they say, well, they're not doing it, the FDA is doing it. The reason being is none of the HIV viral load tests were submitted to the FDA to be approved for diagnostic use. They're approved for monitoring use. Therefore, they should not be used as part of a diagnostic regimen. However, each lab can validate them as a lab-developed test if they would like to use it in that purpose. And as Dr. Rowan says, she can't tell the physicians what to order, and some docs may be ordering the viral load in this situation also. But from the lab standpoint, you have to understand that you would be doing it as off-label, and that could get you in a little bit of trouble unless you have validated it as a lab-developed test. There now recently has been one quantitative assay, viral load assay, that is approved for HIV diagnostic use, and this is the Aptima HIV-1 assay, quantitative diagnostic assay. So problems with the current algorithm then, it's based on a combination test method. You get a single screening result for antibody and antigen, and both antigen and antibody confirmatory tests may be needed. This can give you a longer time to a final result, and a second draw may be necessary if a molecular test is needed, because that may need to be done on plasma as opposed to serum that was submitted for the initial testing. And finally, it does not include a proper confirming sequence for the differentiation assays or fifth generation assays that provide separate antibody and antigen results. So what would you do? What should you do if you're doing a differentiation assay like the Bioplex assay? Well, what you're seeing on this slide is just my feeling. This isn't a formal recommendation from the CDC, or it's not guidelines at this point. But I'm thinking if only HIV-1 antibody is positive, there's really no need for an antibody differentiation assay because you already know that HIV-2 antibody is negative. There's really no need for the diagnostic PCR. You should be able to go right to a viral load in a CD4 count and monitor this patient. If the P24 antigen is positive and the antibodies for HIV-1 and 2 are negative, there's really no need to do an antibody differentiation assay. Again, I would suggest going right to a viral load. Now, the CDC hasn't said that, but so what will the CDC do? Well, what they're doing is asking for data as to how these assays perform in various clinical situations. So we tried to help them out with that a couple of years ago, where we did a study looking at all of the currently available at that particular time. This was done in 2019. We looked at the fourth and fifth generation assays that were clinically available, and we compared all of those available assays on approximately 100 specimens. And what we found out that, I don't have time to go into the data in detail, but the combination and differentiation assays perform similarly on strongly positive specimens. And that specific antigen sensitivity was greater on the Bioplex than on the Alere test. It was the rapid test. In the seroconversion panels, the Bioplex became positive 2 to 3 days earlier than the other methods. Weakly reactive specimens, however, on one assay may be negative on other HIV tests, suggesting the possibility of false positive results, something to keep in mind. And makes me really recommend that you actually look at, if you're doing an ELISA or chemiluminescent type assay or multiplex assay, that you look at signal to cutoff ratios. You look at the values that come off of that. So our main take-home point was that the data supported using more than one antigen antibody testing method, combination method, on low reactive specimens, while suggesting that strongly reactive specimens may not benefit from being assayed by additional antibody or antigen testing methods. We feel that patients with strongly reactive results on one of the quantitative methods may benefit by being triaged immediately to an appropriate clinic or physician for monitoring tests such as CD4 and viral load. So proposed changes to the algorithm that are being considered by Dr. Owen and her groups are basically collecting data to determine the performance of the algorithm with nucleic acid testing at the second step. In other words, getting rid of the differentiation assay at step number 2. They want to look at sensitivity, specificity, cost, feasibility of doing that. Currently, the data indicates nucleic acid testing at the second step does give reliable diagnoses. However, this has not been evaluated in the context of PrEP, the pre-exposure prophylaxis, or ART, the antiretroviral treatment. So this would be one possible algorithm that could come out of this, where you would actually have an HIV differentiation diagnostic nucleic acid test as the second step. So if they're positive on a combination or differentiation assay, you then go to the HIV 1-2 nucleic acid test. And again, like before, if you get your results, if it's positive for HIV 1, you're there, positive for HIV 2, positive for both, we're not really sure with this particular one. And if it's negative, then you want to start thinking maybe we got to check for antibody here. Maybe the patient has antibody, but are they truly infected? We go to an antibody differentiation assay. And another option would be not to do a differentiation diagnostic nucleic acid test, but just to do a HIV-1 diagnostic test, particularly in the US. And again, if it's negative, then we can start dealing with do we have HIV-2 antibody present? This, I think, would be much more cost effective, at least for most of the United States testing. It's another study that was reported at the meeting this past March, where Dr. Wilson at Tampa General, for an ER doc, said that was concerned because if he wanted to do HIV testing in the ER, that the entire algorithm takes longer than an ER visit. And believe me, that's saying something. As we know, most ER visits can last 6, 8, 10 hours or more. And they were using the Gene Expert real-time PCR as a second step, and this took 465 minutes, which if my math is correct is a little over 7 hours. And a drop of over 2,000 minutes from using an on-site Aptima PCR. However, the Gene Expert test is not FDA approved, but the Aptima is. So you're saving 2,000 minutes by doing this rapid, so-called rapid test. The Gene Expert is somewhat rapid, 7 hours. But you get 100% correlation is what they found with standard of care. So they found this would be a useful test to do. So I mentioned before, I'm very strongly in favor of using signal to cutoff values and clinical history in actually interpreting laboratory results. And my corollary for this is not to do lab testing in a vacuum. In the laboratory, we're actually clinical consultants. We need to be in touch with our physicians. We need to understand the clinical situation of the patient to be able to properly inform the physician as to how to interpret the assay. So my questions here, does a patient with a strongly positive HIV combination or differentiation assay really need a confirmatory test? Well, what we had many times in my hospital in Akron, Ohio, was a patient admitted with pneumocystis and a CD4 count of 50 and a strongly positive HIV assay. Why do we need to do confirming tests? We should be able to go right to a viral load for that. However, if we had an outpatient with no previous lifestyle high-risk activities, then we might be a little bit more thinking, could this be a false positive? Maybe we should do confirming tests. And a patient with a low positive HIV combination differentiation assay need a confirming test. Again, the outpatient with a high-risk lifestyle and hepatitis C infection may be able to go right to a viral load. However, the most common false positive result we had was a pregnant woman, often in a monogamous relationship. We didn't always know the answer to that, but pregnant women with a low positive HIV screening test were often negative on a follow-up confirming test. And so that was I figured this particular clinical situation would definitely need to undergo confirming testing. So to summarize now, HIV testing has evolved from the early first generation viral lysate tests to the fifth generation differentiation recombinant antibody antigen tests. The combination and differentiation assays now reduce the test negative window period, so we can detect an exposure approximately 2 weeks post-infection. And the testing algorithm is moving away from Western blots to the HIV-1 differentiation assay and qualitative nucleic acid testing methods for confirmation. However, the current algorithm does not work well for differentiation assays or emergency department practices, and moving to a rapid molecular assay as a second step may provide better clinical care. Finally, laboratory clinician communication can be, and I should say must be, a useful adjunct to final result interpretation. So with that, I thank you for your attention, and I turn this back over to the Bio-Rad monitors.
Hello, my name is Alfredo Villarreal, and I will be presenting a longitudinal specificity study performed at a U.S. public health laboratory in a high-risk population. This study expands on original data previously presented at the 2019 HIV Diagnostic Conference on the Bioplex HIV assay with additional years of data and analysis. This is a continuation of work with myself and my colleagues. A brief background. The introduction of combination HIV antigen and antibody diagnostic screening tests developed over the last decade have improved the overall sensitivity and detection of HIV. While sensitivity of HIV combination type assays has been well described over the years, long-term specificity has not. This discussion will examine the specificity of the Bioplex 2200 HIV differentiating combination assay that was introduced in the US. The Bioplex HIV assay detects and differentiates HIV-1 antigen, P24, HIV-1 antibody, both groups M and O, and HIV-2 antibody, providing those individual results as well as an overall screen result. Our objectives. So in this U.S. public health laboratory, initial diagnostic screening for HIV is performed using the Bioplex HIV assay. The laboratory reached out to us to troubleshoot some observed specificity issues early in its testing. Poor specificity can lead to higher false initial reactivity that can be costly and time-consuming for a laboratory to mitigate. As a result, ongoing data was collected to monitor monthly rolling specificity within any given lot. The collection form is displayed here, and the various possible Bioplex HIV reactivity profiles are shown. Our methodology. So the institution used the CDC recommended HIV testing diagnostic algorithm to evaluate all specimens. Briefly, that means that any initially reactive result was repeated tested, and any repeated reactive results then follow the algorithm guidelines. Supplemental testing was performed on the Bio-Rad Laboratories Genius HIV-2 differentiating assays, and when necessary, HIV nucleic acid testing was performed. Over 158,000 serum samples, approximately of which 75% were fresh and 25% were frozen, were submitted to the Public Health Laboratory for routine HIV testing between October 2016 and October 2020. 49 months were tabulated with monthly detail as shown in the table on the right and is graphically shown on the next slide. Month-to-month specificity was calculated and compared to the Bioplex HIV stated specificity claims. Overall specificity was calculated over the entire period. The Fisher's exact test was used to determine any significant differences, that is p-values less than or equal to 0.05 in specificity. This was done monthly as well as over the entire period. So our results. As mentioned, we tabulated the data graphically and it was plotted so that we could easily identify any trends. The overall specificity during the 4-year period was very high at 99.8%, matching very closely the Bioplex HIV stated clinical specificity claim of 99.86, and was well within the stated confidence intervals of the Bioplex HIV assay. The stated confidence intervals of the Bioplex HIV assay is 99.73 to 99.93 and is noted by the green bars towards the top of the graph. Individual monthly specificity results range from 98.77 to 99.95, and the CIs are noted by the whisker-style plots in black. The monthly testing volume is noted by the purple bars, and one can see the effects the COVID pandemic had on testing volumes during the lockdown. Lot changes were also tracked during the period and is represented by the dashed blue lines. So these are changes in lots, changes that the facility used in lots. A statistically significant decrease is actually shown in the first 5 of the first 10-month periods, confirming what the laboratory saw in their own observations. The decrease is shown as red dots outside of the confidence intervals and traced basically back only to one specific lot. And a decrease in specificity was also observed in October of 2019. However, subsequent performance of this lot normalized after a preventative maintenance was performed on the system. So digging a little deeper and reviewing our manufacturing processes, we found that the initial lot was determined to have a high background noise that caused the lower specificity. We then adjusted our processes accordingly. And being a curious person, I wanted to know what the specificity rate would have been if one removed that lot from the data. When you remove that lot from the data, the N dropped down to 121,000+ samples, and the overall longitudinal specificity improved to 99.86, with a confidence interval of 99.84 to 99.88. And then going back to the complete data set, the overall initial reactivity was 2.09%, and upon repeat testing was reduced to 1.97%. Of the 3,118 repeatedly reactive samples, 89.8, or in other words 2,800 samples, were confirmed HIV reactive by either antibody or NAT testing, indicating the positive predictive value of the Bioplex HIV assay. The overall prevalence was 1.77%, and a total of 308 samples did not confirm, giving an excellent overall false reactivity rate of 0.2%. As previously mentioned, the overall specificity was 99.8%, and this was not statistically significant from the Bioplex HIV assays as seen in the Fisher's exact test calculation, the p-value as 0.132. So doing a deeper dive, one may notice that a large portion of the non-confirmed specimens were HIV-1 antigen only or in conjunction with HIV-1 and 2 undifferentiated antibody profiles. Our investigation discovered that most of those false positives were traced back to that original lot with the higher background. So if one excludes that lot from the analysis, it significantly reduces the number of false positives by 70%, bringing the false positivity rate to 0.14%. So the positivity rate for this population in this location was reduced to 1.66, which seems to be in line with the community that this lab serves. So in summary, even with the first lot specificity issues, the longitudinal specificity was very high for the Bioplex HIV assay during the 4-year period, and when you remove that lot, increased to 99.86%, which is exactly as matched and claimed in the IFU. And it's definitely within the confidence intervals of the Bioplex HIV IFU. Since the lot changes were also tracked during that period, a statistically significant decrease in specificity was observed in that 5 of the first 10 months period and traced to that one specific lot. However, subsequent lot performance was greatly normalized, with 1 month of decreased specificity noted in October of 2019, attributed to needed system maintenance. So in conclusion, the Bioplex HIV assay has demonstrated excellent specificity as a screening diagnostic test and routine specimen testings sent to a public health laboratory. Thanks to my colleagues for helping me with this project, and to the Public Health Lab for allowing us to share this data. And now I'll pass it on to the next speaker.
Hello everyone, my name is Payu Raval and I'm a pathology resident at University of Chicago NorthShore program. I'm going to discuss COVID antibodies cross-reactivity with Bioplex assay, what we encountered, and a small study to investigate the issue. Before we go into details, let's have some background here. So we have seen COVID and its variants in last 2 years, and we have developed new tests and vaccines to deal with it as well. Although we have performance data or interference studies as well, but still we don't know everything about the COVID yet. So I think keeping COVID in mind while you interpret any result or the test is not a bad idea. And now moving on to the topic, this is what we saw at our NorthShore core lab. So in second half of the 2021, we encountered 4 samples which were reactive on HIV screen test. And we use Bioplex HIV antigen antibody screening assay as a screening tool. Our flowchart looks like this. So whenever we have HIV reactive screen test, we run a sample in duplicate from the primary tube. And we confirm the sample on Genius. If the sample was reactive for antigens, we run HIV RNA PCR or NAT to confirm the antigen reactivity as well. So the samples were tested on duplicate from the primary tube on the same lot number of the Bioplex HIV assay, and the results we found were concordant with the previous results. So before we go into further testing part, let me tell you briefly about the Bio-Rad assay we use. It's a differentiating combination screening assay which qualitatively detects and differentiates between the HIV P24 antigen and HIV 1 and 2 antibodies. Assay results for each HIV analyte reflects as index, where less than 1 is a non-reactive and 1 or more than 1 is given as reactive. In certain situations, it happens that HIV-1 and HIV-2 antibody both have indexes more than 1. So in those scenarios, if HIV-1 antibody index is at least 5-fold the HIV-2 antibody index, the system output will be HIV-1 reactive with the index and HIV-2 as non-reactive. Same applies for HIV-2 antibody if it is 5-fold higher than the HIV-1 antibodies. So then HIV-2 will be given as reactive with the index and HIV-1 non-reactive. Certain scenarios are like when you have HIV-1 and 2 antibody indexes positive, like a reactive more than 1, but the difference is not 5-fold between them. So then the system output will be reactive undifferentiated for HIV-1 and 2 antibodies, and the indexes will be given as well. And this is the table showing our 4 positive samples for HIV. So P1 to 4 are the patient samples. The second column shows the analytes, and the top one, HIV antigen antibody analyte, will be reactive if any of the analyte is reactive. The next 2 columns indicate the indexes for the analytes. For the first sample P1, both the antibodies are reactive, HIV-1 and 2, but the difference between them is not 5-fold. One has 5.9 and the other is 3.34, so the difference is not 5-fold. And that's why the result came as reactive undifferentiated. The same thing applies for the other three samples as well. So the difference between the indexes of the HIV-1 and 2 antibodies were not fivefold. They were given as reactive undifferentiated. In addition to that, the antigens were positive too. So for the second sample, the index for the HIV-1 antigen was 33. The third sample had 14.8 and the last sample had the index of 9.75 for HIV-1 antigen. And this is the table showing in-house confirmatory testing. So our 4 samples were tested on Bio-Rad Genius HIV as well as on the NAT, and the results were negative for both, indicating those samples as a false positive samples. This kind of HIV reactivity pattern in a short period of time for our patient population is a little bit unusual. So we did a retrospective look at our quality control data, which was in place, and then we looked at the patient histories as well, which were very diverse, except for the one thing, which was a recent COVID vaccination by Pfizer. So to dig deeper, we reached out to Bio-Rad for a potential cross-reactivity of COVID antibodies with the HIV assay. We sent de-identified samples to Bio-Rad for further workup. They verified the results with different lots of Bioplex, and they confirmed the samples on Genius as well. The results were found to be concordant with in-house results, indicating those samples as a false positive samples. So then we decided to do a small study, and the aim was to determine the cause of false positivity for our 4 in-house samples and evaluate the potential role of COVID infection or vaccination antibodies in the false reactivity of those samples. We made 3 cohorts to evaluate the COVID antibodies cross-reactivity with HIV screening assay. Samples for all the cohorts were acquired from external vendor and they were received in frozen state. They were thawed before the testing. Cohort 1. So cohort 1 included 121 naturally infected COVID patient samples, and we used this to evaluate the COVID antibodies cross-reactivity with HIV screening assay in naturally infected patients. The patient's age ranged from 29 to 77 years, and they were collected between 21 to 133 days after the symptom onset. The samples were evaluated on Bioplex HIV assay, and the positive ones were confirmed on Genius HIV. Results for cohort 1. So out of 121 naturally infected patient samples, 2 samples were reacted positive for HIV-1 antibody on Bioplex HIV assay. And both the samples did confirm on Genius HIV as positive result, indicating them as a true positive samples. So we can say that we did not find any apparent cross-reactivity with naturally infected patient samples. Moving on to the cohort 2. So in cohort 2, we had 91 known COVID vaccinated patient samples, and we used this cohort to evaluate COVID antibodies cross-reactivity with HIV screening assay in vaccinated patients. We included 34 J&J, 26 Pfizer, and 31 Moderna vaccinated patient samples in cohort 2. The patient's age ranged from 33 to 89 years, and they were collected from 7 to 124 days after vaccination. We performed Bioplex HIV assay on 91 samples, and the positive ones were tested on Bio-Rad Genius HIV assay. And now results for the cohort 2. So out of 91, 2 samples were reactive on Bioplex HIV assay. Out of the 2, one was a J&J vaccinated sample and the other was Moderna vaccinated patient sample. And this is a table showing those 2 reactive vaccinated patient samples. So the J&J sample was reactive for antigen with the index of 1.87, and the Moderna sample was reactive for HIV-1 and 2 antibodies, and which was given as reactive undifferentiated because the difference in the index was less than 5-fold. Our 4 samples were Pfizer vaccinated, but here none of the Pfizer vaccinated samples was found to be reactive. Both J&J and Moderna reactive samples were tested on Genius as well, which was non-reactive. Unfortunately, we did not had sufficient quantity of the sample to test for NAT in antigen positive case. So the true positivity cannot be ruled out here. The index here was 1.8, and given the index is very low, we presumed it to be a false positive result. So in summary, cohort 2 had 2 reactive samples on Bioplex, which did not confirm on Genius HIV. So they are false positive HIV results on Bioplex. And since we only had 2 samples tested false positive for HIV, we did not find any apparent cross-reactivity with vaccinated patient samples. Moving on to the cohort 3 now. Cohort 3 included 580 presumed normal patient samples. The samples were acquired from external vendor after 2019, and the patient's age ranged from 13 to 97 years old. The samples were evaluated on Bio-Rad SARS-CoV-2 IgG assay, Bioplex HIV antigen antibody assay, and reactive samples for HIV confirmed on Genius assay. And before we move on to the next slide, let me tell you a little bit about the Bio-Rad SARS-CoV-2 IgG assay. So it is a IgG antibody assay which detects IgG against a receptor binding domain, spike 1, 2, and nucleocapsid proteins of the COVID virus. It can use serum and plasma both. The positive results indicate a recent or a prior infection or an acquired immunity from vaccination. It's a CE marked assay and it is available in Europe. Currently in USA, it is not available. And now results for cohort 3. So out of 580 presumed normal samples, 393 samples tested positive on Bio-Rad SARS-CoV-2 IgG assay, meaning they have a COVID antibody in the system. And 9 out of 580 samples found to be reactive on Bioplex HIV antigen antibody assay. Out of that 9, 7 samples were reactive for HIV-1 antibody and 2 samples were HIV antigen reactive. On further testing on Genius, the 7 samples confirmed reactive, indicating them as true positive, and 2 samples which were HIV antigen reactive did not confirm on Genius. Below is the table showing 2 false positive samples. Both were antigen reactive with low indexes like 1.32 and 2.0. Unfortunately, we did not have sufficient sample quantity to test for NAT in both the antigen positive cases. So here, true positivity cannot be ruled out. But given the indexes are very low, we presumed them to be a false positive samples. And there is one more thing to notice here, that one of the samples was SARS-CoV-2 IgG positive and the other sample was SARS-CoV-2 IgG negative. And this is the flowchart showing how we divided the samples in the cohort 3. So we had 580 presumed normal samples in the beginning, and we did SARS-CoV-2 IgG on 580 samples, then divided them into positive antibody and negative antibody group. So in the positive antibody group, we had 393 samples, and in the negative, we had 187 samples. After that, we did Bioplex HIV assay on all the samples and further divided them into reactive and non-reactive groups. In the positive antibody group, we had 8 reactive samples, and in the negative antibody group, we had 1 HIV reactive sample. We did Bio-Rad Genius HIV on all the reactive samples, and it looks like that in the positive antibody group, we had 7 reactive or 7 positive on Bio-Rad Genius, and 1 reactive sample did not confirm on Bio-Rad Genius. So then we can say in the positive antibody group, we had 7 true positive and 1 false positive samples. Moving to the negative antibody cohort, we had 1 Bioplex HIV positive sample, which did not confirm on Bio-Rad Genius, indicating that as a false positive sample in the negative antibody group. So finally, we have one false positive HIV antigen reactive sample in COVID antibody positive group, as well as in the COVID antibody negative group. We also did Fisher's exact test for calculation of p-value for sensitivity and specificity of the Bioplex HIV assay in COVID positive and negative antibody groups. The p-value less than 0.05 was considered to be significant. The values are like this. The p-value for the sensitivity is 1 and specificity was 0.5466, which was not statistically significant. So in conclusion, the results from all three cohorts showed no correlation between the COVID antibodies and false positive HIV screening results. We also did a data analysis at our institution for Bioplex HIV assay specificity, and we found it to be 99.87 to 99.89% for that specific time period, which is within the manufacturer's claimed range. And now coming back to our in-house 4 samples. So the false positivity of those 4 samples were likely due to various residual non-specific immunoassay binding. Feel free to send me an email if you have any questions, and thank you so much for listening.
Thank you, Payu, Alfredo, and Tom, for your informative presentation. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Ask a Question box located at the far left of your screen. We'll answer as many of your questions as we have time for. Let's get started. Our first question is, what troubleshooting was done to determine that the October increase in false positive results was due to an instrument problem rather than a test reagent problem?
Hi, this is Alfredo. I'll go ahead and answer that question. So in short, when we received the incident report in October was brought to our attention, the first thing that we did was obtain the system log files, and after reviewing those, we noticed that there was an increased value in the detector noise. And then when we checked to see when the last preventative maintenance was performed, it was past due. So then we decided that we would perform preventative maintenance, and we ran the system through a series of tests to ensure that the background was removed. And we went down this road mostly because we saw that the first data point of that particular lot was just fine in their system. And when we removed and when we did the needed maintenance, the data went back to what I would call our normal state.
All right, thank you. Next question. Is it cost effective to use HIV molecular diagnostic testing in low risk, low prevalence populations?
So unfortunately, Tom, Dr. Alexander has not been able to join us, and I would have deferred this question to him. So I'm gonna have to just pass on this particular question, and maybe he'll be able to join us in a little bit if it's possible.
All right, great. Next question. Please define recent in terms of time frame between date of Pfizer COVID vaccination versus collection date of HIV samples.
I'm assuming this is in reference to Dr. Raval's presentation. At the end of the day, excuse me. At the end of the day, the information is not really available to us in detail, but it was stated in the presentation that it was 7 to 124 days after vaccination. If you would like to reach out to us directly, we can go ahead and look up that data as best we can.
All right, great. Thank you. Next question. Was this study conducted on patients who had completed the full vaccination series or partial series?
Right, that's a great question. So we don't as well. We don't actually have that full information. It was purchased from a vendor, so we don't actually know exactly if they were, had the booster shot um, or not. The initial series was there as a requirement, but we didn't know if we actually had the booster information or not. We can check, but we actually believe that there's a mixture depending on when, of course, the samples were collected.
All right, thank you. Next question. Have other vendors showed any issues with cross-reactivity in their assays for HIV?
So the reason why this was brought up initially for the facility at NorthShore University was there was some editorials that had come out with respects to other vendors having some initial issues. I won't say who because I'm a Bio-Rad employee. But Dr. Raval was going to go ahead and do some additional investigations on that, and her intent is to provide additional editorials that could be um, submitted for your all review.
All right, thank you. Um, Next question. Oh, I'm sorry. We are actually out of time with that final question. Thank you again, Payu, Alfredo, and Tom, for your time today and your important research. We would also like to thank LabRoots and our sponsor, Bio-Rad, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, will be addressed by the speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone, and goodbye.